Hello everybody, welcome to the Institute of Health and Social Care Management and the latest in our PowerHour series. Today we're looking at innovative care solutions, contracting and technology for better health. I'm delighted to welcome Mark Slaney as our first guest, followed by Brian Fisher as our second guest. Mark is involved in contracting. He's retired now, but he's been involved in contracting for many years, and he's going to be talking about how we influence the contracting process. I'm sure many of you involved in health technologies in particular and innovative care solutions will be really interested to hear some of the highlights around sort of access provision and such like into the contracting process. And then Brian is going to regale us with his tale about his own technology, which looks at automating the management of high blood pressure, particularly in general practice, but I suspect, Brian, you may allude to elsewhere as well. So we're going to start off, if I may, Mark, I'd like to hand straight over to you. Thank you very much.
Thank you very much, John. Sorry, could I just double check you can see my slide?
You're not screen sharing at the moment, Mark.
I'm not. Oh, I'm glad I checked. I didn't want to waffle on without you seeing it. Any idea what I might be doing wrong, Jade?
So if you click the share button in the top right hand corner and then select window and then choose your application that's got the presentation. I think you're just looking at the application itself.
I am. So how's that?
Spot on.
Brilliant. Thank you very much. Thank you for bailing me out there, Jade. Right, good afternoon. Good afternoon, everybody. Thank you very much for the sorry, I've just realized I can't see my slides now. Just a second. I do beg your pardon. Okay, I'm going to have to look away from the screen, I'm afraid. Thank you very much for the opportunity to discuss contracting. It's probably quite a dull subject for many of you, but many of you will have been involved in probably more social care contracting than I have over the years. I've been involved for about 8 years within the NHS for adult social care. The slides I'm going to go through, everything that I'm going to talk about is on the slide. It's not too detailed. It's aimed at encouraging you to work and engage with the contracting authority. Now that might be NHS, as was my case, but it might also be the local authority, which is usually the case with social care, for instance. There's about 9 or 10 slides. I think I should cover them all in about 10 minutes, and then we've got about the same amount of time for any questions that you might have. So I am struggling a little bit because I can't see the slides on this screen, so please forgive me. You just bear with me. Jade, I'm sorry, I'm going to bail out and ask for your help again here. So I haven't got the slides and I can't make them move from this screen.
Right, I will share them for you, Mark. It's no problem. Bear with me 2 seconds fabulous. And I'll share it for you.
Thank you.
Here we go. There you are. Just say next slide when you're ready for me to move along.
That's perfect. Thank you very much, Jade. So yeah, I've given you a little introduction there. If you could just move on to the next slide, please, Jade. Thank you very much. So just some observations and opinions about contracting. I've paraphrased these from over the years, and I'm sure you'll recognise them. Hopefully you won't subscribe to them, or certainly hopefully you won't by the time I've finished the presentation. So it's bureaucracy, it's time wasting, the contract will never be seen again. The specification and key performance indicators have already been decided and we can't influence anything. There'll never be enough money to make a profit or even cover our costs. Profit isn't allowed. Contract terms and conditions and KPIs are all one-sided and in favour of the authority. And then modern slavery, and I'll talk about that as we go through. Could you go to the next slide, please, Jade? Thanks. So, as you'll be aware of all of this, but I'll just cover it for those that are perhaps not as aware. The contract sets out all the responsibilities for the authority and for the business so that we all understand what our responsibilities are and, more importantly, how they're going to be performed, not just at the bid stage, but throughout the contract. So in essence, if either party fail to deliver, this can be dealt with in a number of ways. To begin with, by reminded of what the responsibilities are, and no doubt there'll be some in-depth discussions about that and why, and then escalating it potentially, and worst case, it would be terminated. That's a horrible term, ended, but it's essentially the jargon is termination. And if both meet their obligations, it's likely you won't be discussing the contract. It might never be seen again, and that would be positive in that instance. However, many things change, as we well know. So staffing issues, budget cuts, legislation changes, and market capacity fluctuations might mean there's less requirement for your services. Thanks, Jade. So the spec and KPIs. This was the case for our previous domiciliary care contract. The contract had failed to deliver in several ways. The contract was with a prime provider, and they had first choice of all the packages of care. What they couldn't do or chose not to do, perhaps for capacity reasons, they then subcontracted those out. And that's where the problems came with that contract. The relationship with those providers, because they were not a direct provider to the trust or the authority, was somewhat strained, I would say. It certainly wasn't ideal, as I've put there, and it did deteriorate over time. Those providers had no input put to the specification or the KPIs. They were just told what they had to do, and lo behold, if they didn't. So for the new contract, there was no prime contractor. We arranged bi-monthly meetings with all of the potential providers. Some of the attendees were representing regulatory bodies or national provider support bodies, and some were from other areas interested in what we were doing and how we were going about it. And not all providers, obviously, as you'll understand if you've got a small organisation, didn't all have the resources to attend every meeting. So we had a communication strategy. We actually had a dedicated communication person for the tendering of the contract. And each meeting, we updated people after the meeting. So we soon agreed the specification, but not all the KPIs. Most reflected our legal obligations and safeguarding, etc. And some were to support reporting at the care boards. But everybody understood that why they were necessary. And we did agree periodic review so that we didn't fall into the trap of them not remaining current, and certainly, hopefully, not being used. Because if they're not used, what's the point? And what information can you gather? So the key to our success was the engagement. We learned from the previous mistakes, but it was challenging to the culture of the authority to go in this route. Thanks, Jade. Never be enough money. I can't help you there, I'm afraid. That could well be the case, but without recovering your costs, you're not going to be there to deliver the contract. So it's a bit of a fool's errand to do that otherwise. And without profit, you won't be able to invest in your business or your people, and you won't be able to retain them probably. Contract failure, I've hinted at it earlier, but contract failure is disastrous for the authority. Obviously, it's not great news for those involved from a provider side, but it really is. Clinically, obviously, financially, reputationally, and not least politically. So just as an example there from our experience, when the previous contract did fail, the chief executive was involved, as was the chief operating officer, director of finance. Obviously, the director of adult social care took a keen interest, and lots of others. And it's, trust me, it's not a great place to be from our side of the fence either. Thanks, Jade. So, as mentioned, with the contract terms, conditions, and KPIs, we agreed most of them with the providers. Yes, some were for the authority alone. However, quite a few were removed from the previous contract because they weren't used or of use to the contract. So there were more KPIs previously, and they were confusing, and they took up a lot of time. And guess what? They weren't reviewed. And that was the fault on both parties, both the contracting authority and the contractor, in my view. So we agreed the reporting with the providers, enabled them a real simple methodology for collecting the information and submitting it once only, and it was online and it was done. The reporting of that information, the collating of it, was then done by our authority manager, who became responsible for working directly with the providers. And that was to help them improve performance, not their performance specifically, but improve performance overall, which in turn enabled them to pick up more shifts where they could, and was also transformational for the authority and the providers alike. So that I would say that was the standout thing that made such a difference with that new contract. Thank you, Jade. Right, I don't want to alarm you, but yeah, maybe I do. I want to provoke you a little bit. This is a bit of a different slant on things, but modern slavery you may well have heard of. I'm sure you have. Hopefully you haven't experienced any part of it. And maybe what I'm going to talk about here will help, but it is a health warning. I have to say the following may never have happened. However, we've recognised that there are causes for concern. This is again linked to the example I'm using with the domiciliary care contract for context, but hopefully you'll pick up some other points from it as well. Thanks, Jade. Okay, so in the heat of the contracting process, as I've said there, you must remain clear-headed and think about possible risks. I've listed a few here which we hadn't. So if you're providing staff out of area, how are they travelling? Who's paying for their travel and their accommodation? Where are they sleeping? Where could they be sleeping? Could they be rough sleeping? Where else could they be sleeping? I think you probably get the gist of some of this. I'm not saying the exact thing because I can't. So I'm just giving you some ideas of what might happen. So who's responsible for all of that? Who's at risk? What are are there safeguarding risks? And what about the service user? Could we be failing our duty of care? You might ask, why would any of this matter? Could it really happen? Well, what I would say is we need to understand the risks in order to have an appropriate managed contract and to manage the relationship with you, the provider. So hands up, we hadn't considered any of these. And I've left one there to think about, and I'll come back to that later, but why modern slavery? Next slide, please, Jade, which is the end. So I've gone through that a bit quicker than anticipated, but my intention is that you'll have some questions that I can answer. And if not, then I can fill in some gaps. And John's always really good at identifying some of those gaps and asking for a bit more clarity. So thanks very much.
Thank you, Mark. I can see we've got Esther here, we've got Victoria as well. I'll go to you two first. Maybe either of you might like to ask a question, or indeed I'll step in because I've got a specific one to ask just while the rest of you are thinking. I'll let Esther or Victoria go first if they'd like to. If not, that's fine. Okay. Well, my question is, oh, sorry, Victoria, go ahead. Yes, please.
No problem. Sorry, I wasn't quick enough on the raising hand. So thanks, Mark, for your presentation there. My experience of contracting in the NHS is like brutally, we're not trained to do it very well, and they have either been with like smaller type of contracts in service provision, but they're still exactly the same elements that you have discussed about KPIs and reviewing them. And I've been a contractee in the NHS as well. And I'm now in my current role, perhaps looking to do some really big contracts. So I would hope that there was a contracting team I can work with. But one of the reasons why I came on the PowerHour was, as I see myself probably going into a contracting position again, to try and pick up some tips. But are there any, or do you recommend any other like training resources or courses at all in the elements of contracting? So I or my colleagues, even though we be working with our procurement team, don't go in blind, and we're not just reliant on our procurement team that perhaps won't make the best clinical or indeed non-clinical decisions for us.
Very good question. And I said before, when we had a pre-meet, Victor, I said somebody's going to ask some really interesting questions that I probably can't answer. The answer to that is not that I'm aware of, which isn't very helpful. So I'll elaborate on that. What I would say is that there is a professional procurement body out there called the Chartered Institute of Procurement and Supply. I would suggest that you could contact them. Their website has information on contracting. I'm not sure how much is available for non-members, but I think that would be a place to start to get an overall corporate, you know, that is the body that most procurement people qualify with. There is only one. It's not like accountancy where there's 2 or 3 different versions. There's only one procurement one. The other one would be John and Co with the Institute of Health and Social Care Management. I'm sure there's some things in there, and looking at the article that came out earlier this week with Sue, it's not Suzanne, I think it's Sue, isn't it? Yeah, sorry. I'm sure there'll be some things there in one of those courses that would help. If not, I'm more than happy to have a chat with John outside of this and see if I could contribute to anything. The purpose of me doing this subject today is I knew that there'd be people that are doing contracts all the time to win business for their organisation and keep their staff going, but don't have any formal training. In our case, and this is because the previous contract failed, and it was the catastrophe that I referred to. And what that meant was not only was the chief exec and everybody else you could imagine involved, but they put resource to sorting out so that we didn't repeat the same mistakes again. And I don't want to talk ill of people, because the people who put that contract together did so with the best intentions, and they did so on the back of a successful contract. And you know, when things are going well, you think, oh, we'll tweak this, add that, do that, and it'll be even better. But it didn't work out that way. So the gist of what I've got in my presentation there is engagement. So if you go back to the contracting authority, and if you've got an idea who that might be, even if you haven't bid for the work yet, talk to them, ask them what support there is, because it's a bit like asking in a job interview, isn't it? So what support is there for me starting this new role that I haven't done before, or I haven't done before with you in that sector? So how can you support us to put the bid together so that not only can we win the business, but we can deliver on it as well? And if you go in with that attitude, they would be, quite frankly, stupid not to find a way to support you. And that support might not be as much as you want, but hopefully it would at least be, this is what we're putting in the tender, or having a workshop. What we were able to do is run workshops with bidders, and not all the providers that bid went on the workshop, but most of them did. And we even had people who had no intention of bidding who went on the workshop because they knew they were going to be bidding elsewhere, and they wanted to understand how to do it. Now, I'm not saying every authority has the opportunity to do that. We certainly didn't have that opportunity for every contract, but we did in this case. So yeah, and I'm, you know, if it's just a matter of me dropping you a line with some pointers on following this, I'm sure Jade or John will pass your information on to me to do that if you've got any further questions, Victoria.
Thank you. That's really
I don't know
helpful.
if I answered everything you asked there, because I did waffle on a little bit. I beg your pardon.
Victoria, as well, you know, we have thousands of members within the Institute. There will be other members of the Institute who are involved in contracting and who may have a little bit more experience than you. And we can put out an APB alert to see if we can find some people who are doing what you're doing, who would be prepared to give you the benefit of half an hour of their time to maybe give you some tips as well. Which specific aspect are you in, Victoria, if you don't mind me asking?
No, not at all.
You're in the health service, or?
Yeah. So I'm hosted at Guy's and St Thomas's, but I'm doing a London-wide piece of transformation. Okay.
Well, I'm sure we'll be able to find somebody, maybe another trust, who might be able to help you in that process, and we'd be delighted to do so. So Jade and I will have a chat afterwards, and we'll see if we can link you up. Okay. Thank you so much.
Can I just jump in there, because I am a bit out of the loop since I retired, but the head of procurement there, or chief procurement officer, I can't remember his name, David, ran a very good ship from what I saw there. I had the opportunity of being down there a few years ago, and I would expect that the team there would be particularly helpful, or would be in a position to help. I can't say they, I can't promise on their behalf, but they were a really good setup.
Right. Mark, can I ask a question from my own perspective, which I suspect would be something that would occupy many of our members' minds when they're involved in this, which is, how does a potential provider, contract tenderer, in other words, ensure that their bid is financially deliverable? Are there any tips or tricks? Because I guess with a fluctuating economic environment and uncertainty around the future of local authority funding in particular, and indeed, dare I say it, health service funding in terms of ICB settlements and such like, which we all know are problematic at the moment. People might find themselves, they've put in a bid which they believe to be financially deliverable, and then through factors that perhaps they haven't considered, it becomes undeliverable over the course of the contract period. And I'm just interested in, have you got any tips or techniques that you would suggest whereby that kind of scenario could be avoided?
Short answer, no. At the end of the day, the bid process will be, this is a specification we want you to bid against. It's quite rare in contracting that you would actually put in there how much budget you've got to spend. Having said that, there was a thing a couple of years ago now, was it the fair cost of care or something like that, where it tried to identify what the anticipated costs would be, both for running the business end for you as the provider and charging the authority, so that there was a fair price put on domiciliary care hourly rates, for instance. I can't remember exactly. I think £19 an hour sticks in my mind, but I don't know if that was the final figure. So there is not legislation, but there is national guidance on what those figures are likely to be. What I would say is, if you have that available to you, you could then put in a bid and say, we can provide this care at that cost. I would say, but you have to put some caveats in, because as I did with what could change.
Putting caveats in is acceptable. I suppose that's what I'm driving at here.
Yeah, it is. It's a difficult one to say that is always the case, because when we get the bids in, we would then put a great big spreadsheet together and put in the costs. And where there are discrepancies or things that didn't match, we'd then go back to that provider and say, what did you mean by that? Doesn't sound like this, or whatever. To then say, I've told the chief exec that they've told us they could do it at £19 an hour or whatever it is, and they'll do everything we need them to do. but there's a list of things here that if these change, and I would link it to CPI or, you know, pay rates. You know, we know that
exactly.
We know that there's been a significant uplift in NHS pay rates last year, and obviously with the doctors and everything else ongoing, I would say it wouldn't be unreasonable to make a reference to that, because we know those pay rises, and I won't be so naive to say get passed down the line through all providers, because they simply can't afford it, but it would be expected that would be taken into account in the contract.
Right.
We certainly would.
Yeah. Well, I'm just conscious that, you know, we've got various members who have handed back contracts halfway through terms because of fluctuations in costs that they simply can't support. And
I don't want to sound as if I'm being critical of my own colleagues in the NHS or local authorities, but it's not unknown for people to change what they expect delivered in the contract partway through at times as well. And some of that is unfortunate, and some of it, well, probably could have been seen at the outset.
All right, that's lovely. Well, Mark, thank you very much indeed. Victoria, you'll have seen that Jade's dropped you a note inviting you to send in over your email. I'm actually at Guy's and St Thomas's. In fact, I'm at St Thomas's next Thursday doing some in-person courses. So if you're around, come and say hi. That's all day, I think, on the Thursday. But there we go. Look, in the hot seat next, we have the one and only Brian Fisher. So, Mark, thank you. You can vacate your seat now. And I'm going to hand on to Brian, who's going to talk to us about automating the management of high blood pressure. Thank you, Brian. And I think you're coming to do a Dragon's Den later in the month as well, I believe.
Yes.
You're pitching,
yes,
so
right.
we'll look forward to that. But over to you, Brian. Thank you.
Yeah, thanks very much for the opportunity. Let's hope that I can share my screen as well. Can you see that?
Perfect. Thank you, Brian.
Okay, and I'll just see if I can move it along. I can. Great. Fantastic. Good. Well, thank you again for the opportunity to speak to you. I'm Brian Fisher. I'm a retired GP in South East London, and Guy's and Thomas is my local hospital as a patient and as a GP when I was GPing. I'm co-director and co-founder of a company called Optimise Health, and our first product is called Optimise BP. And this is a sort of moderately technical discussion about blood pressure and general practice and an app that makes a difference. So I hope I'll make it clear enough and understandable enough for people. Oh, no, I can't move it on. That's interesting. I just got rid
I will share for you, Brian. Don't worry. I
just got rid of your picture and it just stopped moving. So I'll stop sharing, shall I? Or doesn't it matter?
There you go. You should be able to see now.
Well done. That's great. So next slide, please.
There we go.
So for those of you that don't understand about or don't understand enough about high blood pressure, that's the same as hypertension. It's very common. Maybe 1 in 3 adults have hypertension, and it causes some extremely dangerous events and can kill. So it's a serious risk, and particularly because there are no symptoms. So you can be walking around with an astronomical blood pressure and feel completely okay. And very importantly, if we put people on treatment, obviously lifestyle makes a big difference as well. But if we put people on treatment, it more or less eliminates these very serious risks. Next slide, please. But doing that isn't straightforward for a general practice. It's not complicated, but it does take a lot of time. So initially, a clinician has to decide on the right treatment, and that depends on the age or the ethnicity of the patient, their other medication and so on. So that's a clinical decision. but then having that being made, then patients need to be reviewed. Probably somebody on this call might have high blood pressure. So initially you might need to be seen monthly or even more frequently if necessary. And those communications are often face-to-face, but they don't have to be. And because it takes such a lot of time, that's such a common thing. In fact, management of high blood pressure takes 12% of general practice total workload. So it's really quite a significant element. And because of that, it's part of general practice income, and it's an NHS priority. And that's because, next slide, please. It's a sort of drum roll. Because the management of high blood pressure is really not good enough across the UK. It's not just in the UK, but it isn't good enough. So there are over 4 million people who are running around with a high blood pressure and have no idea about it. And GPs are tasked with finding them, but it's a difficult process. And even when you are diagnosed, 30% of people are not treated to target, so they're still carrying a risk. And if we just improve diagnosis and treatment by 10%, we'd save over 7,000 cardiovascular events a year. So a small amount of improvement makes a big difference, and we need to have an improvement across the UK because things are not working well enough. Next slide, please. And we know what kind of pressures primary care is under. So Optimise BP is a solution that we estimate would save over 40% of the 12% of the time that it takes to manage high blood pressure in general practice. And we do this by automating the management. It's a new digital platform providing cost-effective, safe, automated blood pressure management and screening. And it also engages patients in a way that routine care does not. So that's what we're providing, and I want to give you a little bit more detail about that, about how it operates and how it links up with general practice. If you give me the next slide, please. These are the key functions: that it automates the management of high blood pressure, that it helps practices screen for hypertension, and that it allows both either a practice or a primary care network, which is a group of practices close to each other, to sort of look after the hypertensives in their patch. Altogether, you can get a very clear picture of how all of that's looking at one go. Next, please. So the way it works is that, for those who don't know, general practice is extremely electronified now. There's no paper, pretty much, in the practice. Everything's done through the desktop computer, and on every screen can sit the Optimise BP desktop app, which is that little, those things with those icons on it. And really, all the functions of Optimise BP can be done while the GP is in their usual place using EMIS or TPP or whatever GP systems they use. And Optimise BP is integrated with those, so it can take blood pressures that are recorded by patients and put that data back into the clinical system, coded, so that GPs can earn money from it. And we have some clever tricks that make life easier, a great deal easier for practices. So the next slide will give us a little bit more detail about this automation. So as I explained, a doctor will see a patient, decide on the treatment depending on their ethnicity and age and so on, and then will have in their head that this medication could be increased over time, perhaps over 6 months or so, to help control the blood pressure. So instead of all of those face-to-face meetings with the patient or the conversations with the patient, the GP asks the patient to download the Optimise BP app, which is very easy to do. It's on Android and the other app stores. And the patient then, the app starts talking to the patient. It reminds the patient when to take their blood pressure. It asks about side effects. It reminds patients when to go for a blood test. Not all medications require blood tests, but many do. And so it substitutes for those face-to-face conversations and takes the patient through. If everything is going okay, that is, they don't have side effects, but their blood pressure is still not controlled, it will tell the patient then to increase to the next level that the GP has specified right at the beginning. So that's called titration, and that process, which is automated, we think no one else in the world does that. There are lots of other hypertensive apps that enable patients to record their blood pressure, but this kind of interaction between the clinician and the patient is, we think, unique to Optimise BP. So that's the basic message about the automation. Next slide, please. This is the patient app. This is what it looks like. It's very simple. You get push notifications and reminders at key points in the treatment. We've been told it's very easy to use, and there are lots of safety features. So if, for instance, patients are not taking their blood pressure or not responding, not getting blood tests done, the system will alert the practice and stop the patient interacting eventually with the app at all. And it gives patients a lot more information than they normally have. So normally, you know what your blood pressure is when it's taken at the surgery, but apart from that, you really don't know, and you know what drugs you're taking, but apart from that, you really don't know very much about this at all, whereas the app tells you what your average blood pressure is, what the next steps are going to be, when you need to see the clinician next, and it gives you a neat graph of the blood pressure control over time. And really the only thing you can actually do with it, because it's very simple, is to record the blood pressure that you're either taking at home or at a pharmacist or at a GP surgery in the waiting room. Next slide, please. And these are the sorts of messages that the patient gets. It's time for a blood test. Please answer some questions about side effects. And now it's time to get your blood pressure, to check your own blood pressure. So it's very simple, very straightforward, and we hope very clear. And soon all of these messages will be translated into pretty much any language that the patient wants or needs. Next, please. I hope you can hear me. I'm in an attic and it's suddenly pouring with rain. And there's nothing I can do about it, I'm afraid. It's very noisy here. So I'm kind of shouting, and I hope you can hear me over the hurricane. Good. So so I showed you about the management of blood pressure, and this is the other little trick, which is about screening. So as I said, practices are asked, obliged, encouraged to screen for high blood pressure, which means sending out letters to lots of patients, and that can all be done very easily through Optimise BP. So they can send out a message, to all men over 50 who haven't had a blood pressure taken in the last year, for instance. And so practices have a system for doing that. But when those blood pressures come back, patients having taken them, Optimise BP neatly separates out those with a normal blood pressure and separates out those from those with a high blood pressure. And the practice can file and code all of the normal blood pressures at a click, which we don't think anyone else has enabled them to do. And then they can focus on the high blood pressures, which may not mean somebody has high blood pressure, but it's obviously worth thinking about more closely. Next, please. This is what the doctor sees for a particular patient. So you can see the medication, you can see the blood tests, you can see the blood pressures, you can see the average and what next next events are going to be. So it mirrors what the patient sees, but offers a lot more detail, and it enables the clinician to sort of cut them off from Optimise BP if things are not going well, and to restart them if things are going better again later. Next. This is what a patient has said, and this bears out what we think is extremely important about Optimise BP, is that it's improved her awareness of blood pressure, encouraged her to take a more active role, but really without any effort on behalf of the practice. It meant much more regular and comprehensive follow-up. So I have high blood pressure, I'm on treatment, and I don't think the practice contacts me, any more than once a year, if that. So this is much more regular, much more comprehensive than routine care. And in her case, it alerted her, and she had had a much more useful contact with the practice. And she's not young, so this is a very simple app that can be used at all ages. Next, please. So yeah, we in order to get this into the NHS, you have to be assured with it's really quite stringent assurance that goes through the NHS England. We integrate with the big GP systems. We have a special NHS acceptable clinical safety process, and we're registered with the MHRA as a Class 1 medical device. So we can reassure clinicians that we've done all the right things to get to a safe product. Next, please. So in summary, we save time, we improve practice income. It's straightforward. It's screens and manages. And although it's geared for general practice, in fact, we think it's also probably very useful for pharmacies, which now help to manage high blood pressure. And we suspect we're now beginning to talk to hospitals, and we think that they're sort of, cardiologists and maybe kidney people who look very interested in high blood pressure might be interested to use this process to keep managing the people that they would otherwise perhaps just send back to general practice, or even if they're seeing them on a regular basis, they might want some interim information, and it would certainly help each outpatient appointment. So we're investigating that. We're not quite sure how easy that would be to manage. Next, please. This is who we are, the small team. We get advice from a cardiologist, and we have a commercial director. So that's us. Dan is a very active GP. Fraser is medically qualified, but is essentially running the company and doing the tech side of things. Next, please. And that's it. Thank you very much. I hope that's been of interest. And I'm sorry if it's a bit technical, but that's the NHS for you. So thank you very much.
Thank you very much, Brian. Just while everybody else may be thinking of questions, I'll throw my own in, which is, I don't want to predate the Dragon's Den pitch that you make, but who pays for this and how much?
Yes, so we're expecting
who are you selling it to effectively?
To general practices initially. So we're meeting lots of GPs and PCNs, and we're talking to ICBs. So the patient doesn't pay, but we're hoping that practices will pay. We have a few contracts now.
So why would the practice pay, given that they're not necessarily going to be reimbursed for their investment in this, are they?
They want to pay because they want better hypertension care, and because they want to save time. If you're under the cosh as a GP, it's extremely stressful out there, and you do anything to cut corners and to improve care and to make life easier for you and your staff. So that's what this does. And as I say, it liberates about 5% of total practice time, and it will liberate time for GPs, time for practice nurses, time for pharmacists, depend on how the practice actually operates. But that's the hook, that it saves people time and energy, and it almost certainly, we don't know this for certain yet, but it almost certainly will mean that they get a bigger income, because they'll have, it's easier to manage the blood pressures, and they'll have the data there and in the practices.
Thank you, Brian. Would anybody else like to ask Brian a question at all? Mark's got his hand up. Yes, go ahead, Mark.
Yes, thanks very much for that, Brian. That was really interesting, and from a procurement perspective, sounds like a really good way forward if we can save GP time and get them to do other stuff and more of this. They'll get paid more, they'll see more patients. Sounds like a win-win. I'm sure you have, but has anybody approached Wes Streeting yet?
No. Do you know him?
No, I don't. But as the, what is he, health secretary or whatever these days?
Health secretary. He's health secretary.
I'm just thinking he will
and
be
social care.
And so, sorry, health and social care. I think he forgets
My
that
apologies.
as well, John.
Yeah.
It's not just me. No, I think he does. No, I'm just from the perspective of go big, go to the top, let them, shout a bit about it and let them know what the opportunities are. You won't be the only ones beating a path to his door, of course.
I'm sure that's right. Yes.
But you never know. I've spoken to some people fairly high up in government over the years at conferences where I go and make a nuisance of myself when they've done their pitch, and some of them are really open to, he will be open to anything that can save 12% of GP time and 5% of the practice time, because it makes him look good, doesn't it? So I'm not saying you'll get an audience, but it'd be daft not to. And there may be some opportunities coming up through the institute over the next few months. You never know, he may be attending. I don't know if John's got anything up his sleeve there. I'm sure his influence goes very, very far.
You kind of marking me up there, Mark. I'd have to say I rather disagree. I don't think Wes Streeting is at all the right target for this. The NHS has a deplorable record of top-down imposition of technology solutions. Matt Hancock was an easily demonstrable exponent of that. It just doesn't work. You've got to convince people at a local level this is something that works for them. And frankly, if a politician told me if I was a GP to do anything, I'd probably run a mile from them. So I'm sure Brian feels probably the same. But it's a nice idea. Look, we should anything works if it's driving efficiencies at any kind of scale. All right. Thank you very much, Mark. Esther or Victoria or anybody else like to ask a question? Esther, go ahead. Thank you.
Hi. Good afternoon.
Yeah,
I just want to ask if someone go to the GP now to ask for this Optimise BP app, if they will allow someone to be using it for now, or I don't know.
Yes, it's available now, so we're keen to give a demonstration to any practice that is interested, or group of practices. You're with a PCN, I think. Is that right? You're with a PCN, I think. Is that correct?
No. I'm a student from the University of Wales. I'm a student here.
Oh, right. Okay.
Yeah, I'm a student. So
Rocking up USW. Excellent.
Yeah, so I just want to learn. I see what is going on here, and I really appreciate what is that. I'm enjoying the topic. And
okay. Well, yes, we're happy to. It's available now, and we're happy to talk to practices or groups of practices anywhere in the country. So Wales would be fine.
Okay.
We'll see what we can do for you there, Brian.
Yeah.
All right. Thank you, Esther. Lovely to see you, and best wishes to all at University of South Wales. Fabulous organisation. I think we'll leave it there then for today, if we may. We've saved you 8 minutes, everybody. I hope you can use that productively in the rest of your day. Brian, thank you very much. Mark, thank you very much from the Institute of Health and Social Care Management and the wonderful world of contracting and technology for better health. That's it for today. Thank you very much. Bye-bye.